commitment today in joining me on this journey. So this webinar is really about understanding polyvagal theory, our own nervous system as clinicians, and how to really apply this to the clinical work with our clients. The material we're going to be learning today is going to really dive into the science, understand the how, and we'll have some fun along the way because, hey, playfulness is actually one way we heal the nervous system. Before we get started, I suggest grabbing a blank piece of paper and a pen because we're going to do some experiential work along the way as well. So let's get started. Okay. So first, I want to welcome Vic, a little character I created to join us throughout this journey today. Vic standing for Vagal Informed Care, and you'll see him pop up a few times throughout this presentation just to make it a little fun and light, really engaging our ventral vagal nervous system, which we'll learn in this next 45 minutes to an hour. And you'll see him pop up, and he likes to have fun along the way in our journey. All right. So the polyvagal informed philosophy is really us getting to know our own nervous system before we work with another nervous system. And that is really where we are. Polyvagal is learned from the inside out, meaning it's an embodied experience. And we're going to go through some of the theoretical principles today. And we're going to ground them in an experience because it's really the only really the way to understand this. It can be really overwhelming to understand the principles of polyvagal theory and really get to the science. So we'll take it slow and we'll start on the building blocks. As clinicians, we are responsible for being regulated and being a regulating other. And that's really for both our clients, but also the people we work with, our colleagues, our coworkers, and the people we love, the people we live with, our families and friends. And when you work through the nervous system, you take on that responsibility to operate your own nervous system, to regulate your own nervous system, and then to offer that regulation to the people around you. Okay, so here's Vic. Vic's back. So let's get the biology of the vagus nerves in our heads. The nervous system begins in the brainstem, the medulla. It has connections to the limbic system, and basically it's a subcortical system. What is the vagus nerve? So within our bodies, we have different nerves. There are nerves that extend from our brain called cranial nerves, and the vagus nerve is one of these 12 nerves. However, it's not just that, it's more than that. It's one of 12 cranial nerves, but it's also the longest. The name comes from the Latin word vagus, meaning wandering nerve, since it tends to wander from our brainstem all the way through the organs in our chest, and our abdomen, and our neck. Now, what's in this area? We have our lungs, our digestive tract, and our heart. Here are all the parts of our chest and abdominal cavity. The vagus nerve has a big responsibility and takes care of the vital functions of these different areas of the body. It isn't just a giant nerve, it's a nerve with a whole lot of responsibility. So looking at the vagus nerve, ventral and dorsal are part of the same cranial nerve. They exit the medulla together, but they actually end up in different places in the body. The division happens in the diaphragm. So you can see on this image that red line, and that really separates the two. So ventral being supradiaphragmatic, meaning above the diaphragm, and you can look from the red line upwards. It really creates homeostasis. It is above the diaphragm, and the ventral allows us to feel safe and engaged, allows us to communicate our larynx and our facial movement muscles. And it creates really this engagement with others. The dorsal part, looking at the dorsal being where the red line starts and all the way down, really is a subdiaphragmatic area. So from the diaphragm down, and its daily function, its healthy role in our nervous system is in a non-reactive state, is to regulate our digestive system. So it really has a very important function. It's only when it moves into a survival response that it becomes dysregulated and moves out of awareness and moves into collapse. So the sympathetic nervous system is unlike the parasympathetic system, again, which we just learned is the cranial system. It comes out of your brain and skull. So that's what the vagus nerve was that we just learned. The sympathetic, now here, is a spinal nervous system. It actually comes out of the middle part of your spinal cord, which is the thoracic and lumbar regions of the spine. So if you want to actually experience finding it, you find it by holding the back of your neck, and you place your other hand on the bottom of your waist. And this is basically where your sympathetic system exits. It's the chain down your spinal cord. And what the sympathetic nervous system does is regulate our heart and breath rhythms. When we think about even heart math or breathing through our heart and really activating our breath, that's part of our sympathetic nervous system. When it's activated, it activates what's called the HPA axis, and that's the hypothalamus, pituitary gland, and adrenal cortex. They form a circuit, and when you move into that HPA axis, the adrenal glands release cortisol, adrenaline, norepinephrine. This is our survival state. This is when you see high levels of cortisol, or what we would call allostatic regulation. So an increase in neurochemical properties of the body being in that stressful state response. So polyvagal theory. Polyvagal theory is the neuroanatomy evolutionary biology. It focuses our interest in the physiological state of our clients and of individuals by understanding that our different physiological states are really the underlying substrates of our emotional and our behavioral arousal, aggression, or even acceptance of others. So when we start focusing on understanding all of this physiological state system, we start seeing portals for treatment emerging spontaneously. Polyvagal theory provides an updated map of the autonomic nervous system. It defines how to bring the autonomic nervous system directly into therapy, and it really helps clients become active operators of their own nervous system. Organizing principles of polyvagal theory are co-regulation, neuroception, and the hierarchy of the three biological pathways. So let's go to hierarchy. This is really the platform of polyvagal theory. It lets us understand the evolution of the nervous system. 500 million years ago, if we look to the left, start to the left, dorsal vagal, this was the nervous system of our ancient ancestors. It moved very slowly through the world. It could camouflage. It would become immobile during threat. Think about ancient civilization and trying to really hide and not really have the tools or skills to be able to fight. 400 million years ago, if we move towards the middle, we see sympathetic nervous system. That's when the sympathetic nervous system came on board. And now, instead of just being immobile in order to survive, we learn to mobilize. We learn to fight. We learn to flight, run away, all these mechanisms as a form of survival. So we have immobilization 500 million years ago. Then we have mobilization. And most recently, 200 million years ago, ventral vagal formed. And this formed as a way to communicate social and to connect and to learn to be together. So the stories that clients tell themselves about who they are or how the world works begins in the autonomic nervous system. Information is sent through the autonomic pathways from the body to the brain, where it's translated into the belief that shapes daily life. The brain takes the autonomic information and creates a story to make sense of what's happening to the body and in the body. If you want to change the story, start by changing the state. Overall clinical goals of the autonomic nervous system is to have ourselves and have our clients be able to navigate through the hierarchy states adaptively, meaning being stuck in one state is not more favorable. Think about being immobile. If you're immobile versus being fully mobilized and always in fight or flight, ideally as clinicians and even as individuals, we want to be able to go through all these three phases adaptively throughout the day. Okay. So we're going to look at the emergent properties of each state, and we'll start with ventral vagal. So in ventral vagal, our story is one of possibility, where we have healthy homeostasis. We can both co-regulate, we can self-regulate, and we have enough experience of safety and co-regulation in order to learn how to effectively self-regulate. For many of our clients, this may actually be backwards. They may have had to self-regulate because there wasn't safe organizing others to co-regulate with growing up. Think about attachment. And so we want to remember we still need to experience co-regulation at all moments of our life. That's a lifelong need. You don't grow out of not needing to co-regulate. We need connection. In these domains, connection is to self, others, the world, and spirit. That's the connection in ventral vagal. This is where we help our clients resource. We reach out and offer support. There is compassion, there's self-compassion, and this is where we see resiliency form. Deb Dana talks about being anchored in ventral. And if you can really conceptualize that, we really want to resource our clients, ourselves even, to anchor in ventral so that when we oscillate between sympathetic and dorsal vagal, we're able to come back to the anchored experience. And that's biologically where when we can connect, is in ventral. So now we're going to move down to sympathetic. This is responsible for the heartbeat and the breath rhythms and energy to fuel our movements throughout the day. When we move into sympathetic, it's a survival state, and it's a story of an unsafe world and unsafe people. There's a sense of unease and impending danger. Here's where we see clients who might be anxious or panicked, alarmed, or constantly in a hypervigilant state. This is where clients experience that no one is their friend and everyone is their enemy. This is a us versus them, me versus you type of experience. It is disconnected from self, it is just disconnected from others, and it's disconnected from the world and spirit. Now let's go to dorsal vagal together. In the emergent properties of dorsal states, its everyday responsibility is for digestive process. But when we move into a survival state and move from sympathetic to dorsal, the story is one of despair. The body goes into conservation mode. Heart rate slows down and digestion is impaired. Everything in the body slows down. This is where we see our clients experience a sense of fogginess or even feeling numb. Energy is drained. A lot of clients talk about this untethered floating feeling and being disconnected. This is actually where we see dissociation. In this state, we biologically cannot connect with others. So this is an image that I really enjoy using with clients in educating them on their type of arousal, their type of autonomic nervous states. And even though it shifts up the hierarchy, we can really look at even to the right of this image, looking at parasympathetic, we see biologically insulin activity increases, endorphins that help numb and pain threshold increases. This is in dorsal, that emergency state. We see the decrease in blood pressure, a decrease in temperature, even social behavior, immune response, eye contact. When we look at sympathetic and the red in the middle, we see an increase in heart rate. That adrenal gland, the HPA axis that we spoke about earlier, is activated and turned on. So we're seeing pupil size increase, oxygen circulation to vital organs, and fuel availability, all ready to fight or flight. We see a decrease in fuel storage and insulin activity, salivation slows down, and even the abilities of the immune response decreases. Looking in ventral vagal state, we see an increase in digestion. We see intestinal mobility, really an increase in immune response, the feeling of rest and recuperation of the biological body system. We see oxytocin increase and the ability to relate and connect. We see the decreases in defensive responses. So the autonomic ladder, which is what Deb Dana created and helped getting to know our states, lets us translate our basic knowledge of the autonomic nervous system into everyday understanding by imagining the autonomic nervous system as a ladder. So we see here at the top of the ladder is ventral vagal, the state of safety and connection. And when clients are confronted with a challenge that overwhelms the capacity of the ventral vagal state to maintain regulation, they actually move down the ladder, one step into mobilization of the sympathetic nervous system in some form of fight or flight. If that doesn't resolve the challenge, the final move to the bottom of the ladder into the immobilization and disconnection is in the dorsal vagal system. From the bottom of the hierarchy ladder to return to the state of ventral vagal, clients have to safely move through some sort of mobilizing energy of the sympathetic nervous system. Clients and even ourselves travel through the ladder many times a day in small and even sometimes very extreme ways. And if we even look at the little character on the bottom, it's no wonder that sometimes safety and hope feels unreachable. It's a long way up back to climb and a big shift in our nervous system. So now I'm actually going to invite you to get your piece of paper and pen out, or pencil, or whatever you have laying around. And we're going to construct this exercise together. This is actually something I do in session. And I love to map our own systems. You can do this with your clients and create their personal profile map of their nervous system. I even reference it in session many times and keep it in their chart or have it accessible in session to check into what their nervous system is experiencing, whether I'm doing DBT skills or history taking or even EMDR resourcing. It is a great tool to incorporate to check in what is the body experiencing, what is the nervous system speaking. So one of the rules Deb Dana teaches us is that we always want to end in ventral. So we're going to start in the middle of the ladder in sympathetic. Then we'll move to dorsal and end in ventral. This map is a great way to befriend the nervous system and not get overwhelmed by the experience. This is even something I do with colors and do with expressive arts. I have one right here to show you, a client of mine. And we painted, after completing the map, what ventral vagal as a color would look like all the way down to dorsal, or something like this. So everyone's nervous system, just in 2 clients, can be completely different for individuals. So let's try it together. So let's go to the middle of the map in sympathetic. And remember, this is the survival state. So it's the panic, it's the fear, worry, anger, rage, and frustration. And when you have that sense of what you're like in this state, I want you to write in the middle of the map, what does this happen to your body? What happens to your body in this place? What are some of the things you do in a sympathetic fight or flight? What are some of your feelings? And what are some of your automatic thoughts? And a lot of our clients are actually really familiar in this place. Think about how your sleep is even impacted here, or your relationship with food. Think about compulsive behavior in a sympathetic state, or even substance use. Think of these things, of what you're doing in a sympathetic fight or flight. So we have these two sentences, and I do this with clients, that we're going to fill out for each state. So when you're in this place of sympathetic, when your body is responding in fight or flight, I want you to really tune into what your nervous system is responding and answer the question or the phrase, I am ... and the world is ... I'm going to show you here. A client might say, I am, I'm sharing one, irritable, on edge, craving a routine. And the world is volatile and can be triggering. Okay. And let's move down to dorsal vagal. So I want you to be really mindful that dorsal vagal is that immobilized, collapsed. And let's let a tiny bit of energy there, because we also don't want to really be experienced in the feelings of being shut down and collapse. And I want you to begin to write on the bottom of the ladder, in the state of dorsal vagal, what happens to your body? What do you think during this state? What do you do during this state? And what do you feel? And for a lot of our trauma clients, this is actually a very familiar place. Again, think about how sleep is impacted in dorsal vagal. Think about how the relationship with food is impacted in dorsal vagal. Substances and compulsive behavior. Think about how those show up in dorsal vagal. And we are going to complete the same 2 words. I am. So this client put shut down, alone, very low energy, and the world is existing, uninteresting. Okay, so now I want you to take a moment and just breathe. So we're going to move up the ladder. And to move up the ladder, we need some immobilizing energy to get us out of the immobilized collapse feeling. So take a stretch if you need to. We're kind of halfway through. There we go. Thanks, Amanda. We're going to move up the ladder. So think about, this is really your nervous system. Sympathetically, we need a little bit of mobilization to get back up there. So here we go, ventral vagal. So the one of safety, joy, play. And I really want you to let your body fill up with this energy, this ventral vagal energy. And we are going to finish the sentence. I am and the world is. And I really want you to think about sleep, relationship with food, substance use, and compulsive behaviors, how they show up when the world is safe, when you feel connected, how your body's experiencing joy, the feelings within ventral vagal. And let's finish the sentence. So I am. Sorry. So I am, and I have a client who wrote internal calm, outside extroverted, adventurous, and spontaneous. Can't see that too good, but, and the world is welcoming, calm, and at ease. So just pretend that's all the way up in ventral. But the point is that when you really work this through with clients, it's an excellent place of creating their own personal profile map. And truly, everyone's is totally different and uniquely theirs. So it's just a great way, even for yourself, to understand what your nervous system says in each of these states. And yes, experiential art exercises are great too. A lot of times clients love to put color to making their ladder. So they'll write the words in color or do collage and find images. If there's a lot of pre-verbal trauma and words can be even difficult to access, thinking of dorsal vagal. So images, you know, there's multiple ways that you can really customize this for everyone's needs.
Kristina, I normally don't ask a question during, but we did have one come through that I think is a bit more relevant to the exercise that you just did. When you say end in ventral, do you mean end the session in ventral as well, or just the exercise?
Great question. So the exercise, definitely, we definitely want to, when we're doing the personal profile map, I'll go back there. We always start in sympathetic, move down to dorsal, and move back up to ventral. That's Deb Dana. That is her kind of hard set rule. But I also think that's a great parallel to session, because we might have a client who comes into session in sympathetic or in dorsal vagal. Actually, more or less, that's why they're coming into session. And we ideally want to get them to a ventral vagal state. Think about EMDR, opening up trauma, or even narrative work. We want to really make sure that we close up the session by being able to have our clients end in, yes, absolutely, in a ventral vagal state, being able to have some form of anchor that allows them to feel safe and connected, whether it's with you as a clinician, whether it's in the safe space that they're in. I think that is an excellent way of paralleling this exercise to session and looking at session exactly like an autonomic ladder. Great. Thank you, Amanda. And great question. Okay. So when we think of, oh, sorry about that. So when we think of ventral vagal, sympathetic, and dorsal vagal, we really look at the experience of neuroception. So in ventral vagal, there's a neuroception of safety. In sympathetic, we have a neuroception of danger. And dorsal vagal, there's neuroception of life threat. Erase this. So what is neuroception? So neuroception is the term Dr. Stephen Porges created to refer to detection without awareness. Neuro coming from nervous system, inception coming from perception. The nervous system is a subcortical system away from the thinking parts of the brain. It responds to the visceral response of the body. It responds to the environment and the connection with others. This intent listening happens below the thinking parts of our brain. So Vic is back. Vic wants to have a little bit of fun, get us back into ventral as we deeply learn about all of these science-based theories. And so some of the ways you can experience neuroception is through image. So I'm going to take you through a journey of images. And I would love for you to invite your brains, your thinking brains, what we would say the prefrontal cortex, to just take a step back, take a step back and stay at a story, and just no rationalization, just follow your nervous system. And we're going to go through an autonomic journey. I want you to just tap into what your nervous system is saying from these images. And let's go on this journey with Vic. So just take a moment and notice what your autonomic experience was. A lot of people are afraid of snakes. Some people are curious and want to get to know them. We all have a different autonomic experience. And we're going to keep going. So your prefrontal cortex, the rational part of your brain, is probably trying to make stories out of these images. But just listen to your nervous system. Neuroception is actively asking, in this moment, am I safe or is there danger? We move into the autonomic state that brings the energy needed to effectively manage the experience. So when we think of our clients who grew up in an unsafe or unpredictable environment, this can be actually really difficult for them to experience neuroception. If the nervous system has had an inability to calm the defense system in a safe environment, it's actually called a neuroceptive mismatch. Since the autonomic nervous system is activated in a habitual protective response pattern, we'll actually see clients in a hypervigilant and alarmed state. This is an alarmed person walking through the world. And actually enable to really cue into the ability of fostering neuroception with their nervous system. So what we want to do is really begin our work as clinicians to co-regulate. So one of the ways in beginning co-regulation with our clients or with others is really creating a strong profile of ourselves. So we call it a vagal superstar. So what encompasses vagal superstars? We look at strong social support networks, practicing exercise and self-care every day. We look at altruism, regulating our own nervous systems. We look at practicing mindfulness, positive emotions towards daily relationships, and meditation. So co-regulation is what we call a biological imperative, meaning it is something that we don't survive unless we have. We come into the world and we have this need to be met by another human being. Think of attachment, or even an example of co-regulation could be the relationship between a mother and her baby. So if a mother is calming her child and the child responds by relaxing or vocalizing in sounds of contentment, this has a reciprocal effect of calming the mother. Now, if the infant continues to be upset and doesn't respond to the mother's attempt to settle, the mother will actually also experience the visceral response of being upset herself, frustrated, worry, anxiety. So that's a perfect, really primitive biological way of seeing co-regulation. The nervous system has a drive to survive and a longing to connect. So sometimes they're working together and sometimes they're working in opposition to each other. The nervous system is sending and searching for cues of safety and danger at all times. The signals we send the system to other systems either co-regulate and create new possibilities if they're actually cues of safety and connection, or they'll increase our reactivity and influence a primitive habitual response. So we're either co-regulating and feeling safe to move into social engagement, possibility, and connection, or we've gone into a total habitual survival pattern. And we see this with our clients and we experience this ourselves. All right, here's Vic again. He wants to really show off what adaptive co-regulation in two individuals in a ventral vagal state in therapy. Go, Vic. So from a clinical perspective, polyvagal theory gives a narrative for our clients to actually understand their behaviors and their feelings. It gives us as clinicians portals in understanding how to direct our therapy. And understanding our client's physiological state is an opening to see how they react to the world. What we have to understand is that if we can get the client out of a stuck physiological state like dorsal or sympathetic and into a physiological state such as ventral, that emergent properties of social interaction or even adaptive behavior adds to all of our therapeutic interventions. Think about DBT when we are in emotional regulation or distress tolerance or even interpersonal effectiveness. If we don't understand the nervous system, there is going to be the inability to biologically connect. We can focus our client's physiological state, their emotional state, behavioral state, as opposed to focusing on the problems that they may be bringing into the clinical setting. Once we focus on the individual's physiological state, we can start creating neural platforms to facilitate efficacy in our treatment models. So even think of EMDR when we're resourcing a client and we want to be able to have them grounded in order to process past adverse childhood experiences or traumatic experiences, we need to have them anchored in ventral vagal. So I love this quote by Dr. Stephen Porges about trauma. And he states that trauma is a chronic disruption of connectedness. So it's such a simple way to think about trauma. And if you think for a moment about the experience of some of your clients and think of this even through the lens of attachment, there's a lot of disruption in the capacity for connection with others. A lot of the times, the traumatic experience of attachment is disconnection. So adding this to trauma and the autonomic states, we see in traumatic individuals or presentations or cases that co-regulation is pretty much unpredictable and unsafe in a lot of these experiences. There's an inability to self-regulate. There is even a decrease in accessing ventral vagal. We'll see a lot of clients or individuals stuck in cycles of sympathetic mobilization and dorsal, and really spend majority of their lifetime and day in those cycles. So as we're integrating into practice, Polyvagal's principles really emphasizes three major takeaways for today: the physiological state, the emotional state, and the behavioral state. So as we are going to heal the nervous system, one of the ways we do that is through listening. We also can do that through bottom-up approaches, including breath works, yoga, to name a few. One of the other ways that I most recently learned about is through listening. So listening is actually dependent upon regulation of the autonomic nervous state. So to ask clinicians, we would say physiological states, or to our clients, their heart might be racing, they're mobilized, or their behavior is that they feel sick to their stomachs and it goes to their gut. And clients' physiology is often manifested in their behavior or even somatically. Physiology is reflected in also the autonomic nervous system. So we know this in the work with our clients. If there's a vocal tone that's prosodic and has a nice regulated sound, or we have really a client who has pressured speech and really needs to be tight and get everything done, that you know there's something changing in their physiology. Their ability to interact with you is depending on your physiological state, your gestures, your connection, your vocal tone. Listening is a pathway to change neural state. So one of the ways we use listening as a functional exercise is actually Dr. Porges' Safe and Sound protocol, which is something I've been newly certified in. It is an interactive neural regulatory process. The nervous system is functionally reaching for the stimuli and processing it. It's creating new neural feedback loops that enable us to extract the meaning of certain sounds. The whole focus of the SSP protocol, so sound sensitivity or safe and sound protocol, is that it can be conceptualized as a neural exercise of the mechanisms, especially in the neural regulation of the muscles of the middle ear. Another way, so let's say you don't have access to SSP, one way to heal also the nervous system is through breath. So we'll see breath works such as piercing your lips as if you're drinking through a straw, and you breathe in for 4, hold for 4, and breathe out for 8. So we'll practice that together. Hold and blow out for 8. And you can do that multiple times with the client. But what that really does biologically is the exhale, the long exhale, is what's activating a parasympathetic vagal response. When you inhale, you don't want to go too long or too fast because it's a gasping for air and it activates the sympathetic nervous system. So even as simple as that is what we can integrate into practice. So when we look at the SSP and just practicing the protocol within our system, if that's something you know, at some point it would be great to do another webinar in discussing how incredible this modality is. But the SSP Safe and Sound protocol addresses social engagement difficulties, auditory hypersensitivities, anxiety, trauma, PTSD, mood dysregulation, autism spectrum, even auditory processing and emotional regulation difficulties. And that all has to do at the end of the day with regulating and healing our autonomic nervous system. And Vic is back for one last appearance for any questions we might have. So thank you all for joining me today. It's been a pleasure. And this is such a passion, and I'm so grateful for everyone who joined and who's really interested in this as well. So I take it to you, Amanda.
Yeah, thank you, Kristina. This was a beautiful presentation, so thorough. I can't wait to hopefully have a follow-up and hear more about this. But let's jump right into questions because we do have quite a few. Again, as a reminder, if we're not able to get to all of the questions, we will respond to you personally and share with you the answers. Kristina and I will connect and we'll make sure that we get you answers to your questions. So I am going to start with a few questions that were submitted as part of the registration process. So Kristina, I know you spoke to this already, but what are some concrete skills related to the polyvagal theory to teach patients in recovery? If you could highlight just one or two.
Sure. So even everything from singing or laughing, breathing and movement. We can even look at having individuals, anything kind of sensory that engages the system in a healthy way. There's so many little things that we could do, even mindfulness with paint. Anything that we can do to get the nervous system back into a ventral vagal state is ideally, it really is a way that you can incorporate creativity in your own work and just really create safety and connection with your clients.
Absolutely, absolutely. Here's another question that was submitted. In my work as a yoga therapist, I am permitted to do hands-on work with clients. As a substance abuse counselor, that's not the case. Are there any verbal interventions or suggestions that might be appropriate to use in a group setting?
So actually, yoga is one of the simplest exercises for stimulating the vagus nerve, but it's also so wonderful for promoting body relaxation and general wellness. So if you don't, it can be just super simple. It doesn't take much to really go and stimulate the vagus nerve. If you can't do it for a long period of time, anything part of the yoga experience can be calming. So don't underestimate yoga. It can actually be quite powerful for the vagus nerve.
Wonderful, thank you. How do we teach or utilize polyvagal theory in a maximum security setting with patients who are severely mentally ill with trauma histories?
So that's a great question. And I think we kind of integrated that throughout the webinar on just everyone has a nervous system. And we all have a biological need to connect. So whether you're in maximum security or even in outpatient setting, all we want to do is I would start with an autonomic ladder. And being able to even process that in a group setting of what their nervous system is saying, or identifying if they're feeling activated and dysregulated, where are you at in your nervous system? You begin to tame it when you begin to name it. And I think that's the first step in that kind of setting.
Absolutely. How are eating disorders correlated with past trauma?
So when we even think of when we went through the autonomic ladder and I said, you know, look at the relationship with food in all these all these three states. So being in fight or flight, the relationship with food, being mobilized when the world is on edge, and you'll have an eating disorder, maybe binge eating, where you want to stuff it all down because it's so much for the nervous system to handle. Or you have bulimia, where it's so activating that they want to it actually regulates the larynx. So the food consumption is actually what is really primitive and the quickest way for the body to go ahead and regulate the parasympathetic. So they're really correlating with each other. Yeah, there's a lot there. That's a whole different webinar.
Yeah, that is definitely a question we could probably talk about for much longer, but simply said, absolutely. Thank you. So jumping into some of the questions that were submitted throughout your presentation, how would you modify this approach when clients are severely dysregulated on a daily basis?
So I actually don't even think we need to modify it. I think we need to apply it in a daily basis of individuals who are dysregulated. We want to start with understanding what's happening physiologically. So the emotion is starting in the body before it's going up here in the prefrontal cortex, where they can verbalize, I'm so angry. They're feeling angry before anything else. So we want, number one goal is to get them in ventral vagal and to be able to heal their nervous system.
Absolutely. And do you use this in group therapy as expressive art after explaining polyvagal theory?
Oh yeah, I actually did it yesterday. So those are actually fresh and not even dried yet.
Yeah, you're not kidding.
Of course, I'm not kidding. It's a great way, even when if it's a closed group and in the first few sessions, you want to collaboratively understand group dynamics or individuals. That's a great way of getting everyone's profile, and even doing expressive arts on that as a way to even the expressive arts in itself is a social engagement exercise. And then being able to share that with others. So yes, absolutely, highly encouraged.
Is someone who is avoidant of a challenging situation in dorsal or in sympathetic?
Oh, great question. So I think it could be all relative to what their nervous system. So maybe to someone who's avoidant, what if the body's avoidance can be felt like a sympathetic response? Or what if someone's avoidance feels like shut down, shame, trapped? So I think the context of the avoidance is actually relative to the body. How is the body storing and experiencing avoidance? I think it could actually be both. I think we see avoidance as like tight, and they don't want to look up, and they can't make eye contact, and they're avoidant, and their body language is disconnected. Or avoidant can just be completely deprivation of energy and numb. So I think that it could play on both systems. We have to look at the body language and how avoidance is coming up.
Absolutely. Yeah. Well said. I think we have time for one more question. There are a handful more we're not going to get to, but we will circle back to you via email. So this last question for you, Kristina, how do you predict that the pandemic will impact long-term connectedness in general?
Yeah, so actually that's a great question. When I finished up the Safe and Sound Protocol certification, there's a whole, Deb Dana and Steve Porges do a great job, Dr. Porges do a great job on even addressing social engagement, and how even the SSP protocol, the listening system, can create connection. So I love that question, because we can even create connection virtually. So if you look at my body language, if I'm like this and maybe I've looked really interested and my vocal tone is listening and I'm curious, we can create social engagement virtually. Or if I'm pulled back, my hands are crossed, we can do social engagement virtually, and really be able to start to ask the client, in my background, is there anything that's throwing your nervous system off? So for some people with OCD, sometimes the wall, if a picture is crooked, might really engage their nervous system in a different way. So we want to make sure social engagement virtually, thinking about the pandemic, being disconnected for a while. Of course, we're going to have a lot of individuals who haven't experienced ventral vagal in a while. We can do that virtually. Of course, I love the heart space when we think of EMDR and heart math, but that's okay. And we can also allow our clients to experience safety and connection through our room, through our body language, through our voice, through our smile. There's many ways. Awesome question.
Yeah, wonderful. Thank you, Kristina, so much for that overview. And again, for this entire presentation, there's so much interest and dialogue in this. I'm sure we could speak for another hour. So perhaps in the future, we will look to welcoming you back for another webinar. I know everyone would love to hear more. So speaking of additional webinars, Karen Treatment is going to be providing some additional webinars in the coming weeks. So next week, we're hosting a webinar entitled Treating the Jewish Patient, Breaking the Stigma and Acknowledging Faith-Based Practices for Success in Recovery. And that presentation is available for a CEU credit through the American Psychological Association. Additionally, in June, we are hosting a webinar on treating trauma and PTSD, specifically in older adult population. And this presentation will also receive a CEU credit. So if there's any interest in these upcoming webinar events, please don't hesitate to reach out or register on our website at www.karen.org/webinars. Also, we hope to see you for our next installments of our ongoing virtual open house series. This summer, we are so excited to feature Ocean Drive, where Kristina is herself a primary therapist here in Florida, and our Grandview Men's Program up in Pennsylvania. So more information to come. Please be on the lookout. Those invites will come directly to your email. As always, please don't hesitate to reach out to myself or to any of your local regional resource directors at any time for additional information, resources in your community, or any questions about Karen specifically. We are so happy to be a resource for all of you. Thank you so much for joining. We wish you health and wellness. Have a great rest of your day. Take care.
Bye.